Good afternoon and a very warm welcome to everyone online. I'm Florian Tinne. I'm with the European Observatory on Health Systems and Policies, and it's my pleasure to moderate today's webinar on addressing inequalities in cancer prevention and care. Today marks the third webinar in our Spotlight series on beating cancer in Europe, where we are exploring topics in cancer care, research and policy. And we have a fantastic panel with us today who I will introduce in detail in a minute, and I'm really looking forward to hearing from them. Together with my colleagues Louise and Erica, we'll be the moderating team. Before the keynote, I'd like to provide just very briefly the context of today's topic. So Europe's Beating Cancer Plan, or the EBCP from 2021, is one of the European Commission's key responses to the growing burden of cancer in the EU, and really a new approach to cancer prevention, treatment and care, addressing the entire disease pathway. Building on this, the Commission has asked us at the European Observatory to look at the implementation of the EBCP across all of its dimensions, so prevention, early detection, diagnostics, quality of life, etc. And we've started doing this through the action OBS, Learning from Progress in Addressing Cancer in Europe, or short OBS-PACE. This PACE project has at its core a network of national cancer experts from across all EU countries who've written up case studies on actions tackling cancer in their countries, and I'm delighted to have 3 of them on the panel with us today. We will learn more about this in just a second from Béatrice, but really key to the project is that through qualitative analysis, we provide a better understanding of the national cancer control situation in EU countries, while at the same time drawing out wider health systems lessons. So in OBS-PACE, we are building on synergies with other European projects, we are informing the implementation of the EBCP and the EU Mission on Cancer, and we are contributing to the European Cancer Inequalities Registry. Now we'll hear first more about the OBS-PACE project and some of its key findings so far, before we then look into a set of concrete initiatives from Croatia, Ireland and Italy on how cancer care is being improved there. We will then bring it together and highlight what we can learn from these experiences. Just a very brief note on housekeeping. As usual in our webinars, we are leaving ample time after the spotlights for your questions, so please do feel free to share these via the chat function. Erica and Louisa are monitoring these and we will certainly pick them up. So without further ado, may I invite now Béatrice Durvy, who is a research fellow at the Observatory's hub at the Technical University of Berlin, to come in for the keynote. Dear Bea, really great to have you with us today, and the floor is all yours.
Thank you. Thank you very much, Florian, and welcome to everyone. I'm very happy to be here today. I will share my slides. I hope you can all see it. So as Florian mentioned, I will provide a brief overview of the OBS-PACE project and also our preliminary findings. So OBS-PACE aim at improving the understanding of national cancer control situations and policy actions across EU member states. It is very much building on Europe's Beating Cancer Plan's dimension that you can see here and probably recognize here on this figure. And we have 2 key objectives. The first one is to collect innovative actions implemented in the cancer field to provide insights into health systems components and health systems enablers and barriers. And the second objective is to identify emerging themes across the cancer field along, again, those health system components. As mentioned by Florian, our work is supported by a network of national cancer experts across the EU member states. And those experts are working in ministries, public health institutes, research centers, universities, NGOs, and they are helping us draft or collect case studies of innovative actions that have been implemented in their countries to better tackle cancer, sorry. And with this innovative actions, we have a quite broad definition because we understand innovative actions as innovative in the country context, and this might be implemented at the national, regional, or local level. We are building our work on two frameworks. So the first one is, as I mentioned earlier, Europe's Beating Cancer Plan, so really looking at the entire cancer care continuum. But we are also approaching this with a health system approach. And so we've been building on the health system performance assessment framework that has been developed by the observatory. And I won't today go into detail on this framework and describe it because it is not the focus of this webinar, but just to illustrate how we are looking at the different health system functions, so governance, financing, service delivery, and resource generation. And we are particularly interested in the enablers and barriers within those four functions. And we are also looking at how those initiatives have impacted the intermediate objectives and final goals of a health system. So looking at the impact on access or improved health or improved efficiency, for example. To harmonize our data collection, we have developed a template that is filled out by our experts of the network or the experts of our experts. In this template, we're really looking at the implementation of those innovative practices. So we're asking, of course, about the background. So why this action was developed, what was the gap that was identified, what was the planned action, but then also asking about how it was implemented in practice. Did it differ from the original plan? And then also asking about outcomes, sometimes only preliminary if the action has been implemented quite recently. And then we are asking also elements linked to the health system. So again, enablers and barriers at the health system level during the implementation, and also impact on the health system goals. And finally, we're also asking how experts their lessons learned, because we really think that there is a really nice opportunity here for cross-country learning, or even sometimes intra-country learning if it's a local initiative. And so, as mentioned by Florian, these findings are contributing to better understanding the national cancer control situation and policy actions in EU countries, but also providing essential qualitative and contextual health system information. All our case studies and all our work are available on the OBS-PACE website, and I think that my colleagues Erica and Louise will share the link in the chat. So far, we have published 21 case studies from across 13 EU countries, but there are a lot more underway. Here I have put again the framework with the EBCP dimensions and put the number of case studies for each of those dimensions. If you add up the numbers, it does more than 21 case studies, because many have multiple dimensions that they can be associated to. But what this shows is that the case studies are spanning across the entire cancer care continuum. We have a mix of case studies that have top-down approach or bottom-up approach. And beyond the cross-cutting themes from the EBCP dimensions, recurring cross-cutting themes include the use of cancer registry data, as well as the movement towards a better standardization of care. And we think that all of those case studies, we hope that they can bring insightful information for experts who want to tackle similar challenges in cancer care or want to implement a similar initiative. But we also think that this is an opportunity for cross-cutting analysis. And so this is what we have started doing recently, and we have a few preliminary findings that are already showing that recurring lessons for health systems emerge. And so for now, we have focused on the different health system functions and again looked at the barriers and enablers at the health system level. And so if we are looking at the first one, the governance function, recurrent enablers are a strong political commitment, clear strategy, and well-established responsibilities. It also seems that multidisciplinary collaboration and strategies that are relying on participatory mechanisms or strategies that are using piloting before scaling tends to be more successful, or at least this was seen as an enabler to success. And also that it seems key to have monitoring and evaluation processes that are really thought from the start of the design and really within the design of the initiative. On the contrary, frequent shifts in political priorities and fragment in governance are often reported as barriers to implementation. Looking at information systems, cancer registries represent key assets to data-driven decision-making. However, there are also challenges that you probably recognize also from your work in health systems, notably the worries linked to data protection, lack of interoperability or resistance to new technologies. If we're looking at the financing function, securing sustainable funding is, of course, a critical prerequisite to success. This may be done through joint EU investments, for example, and adequate funding for administrative and data collection costs should not be overlooked. And so if some of these elements are missing, then they may become barriers. Looking at resources and the example of healthcare workforce, it seems that investment in specialized roles can improve patients' experience. Reporting enablers include multidisciplinary expertise, the creation of really dedicated roles, but also specialized training programs. However, barriers that are probably common when it comes to healthcare workforce are disparities in geographic distribution and health workforce shortages. And finally, looking at service delivery, patient experience and health outcomes need to be enhanced by multidisciplinary care, provider networks, standardized patient pathways, and clear referral systems. And for this requires formal agreements, but also the existence of collaboration mechanisms. And of course, a recurrent barrier may be administrative complexity. So I hope that this presentation inspired you, and in case while listening to this webinar you feel like you might have an interesting case study that you would like to share and publish on our website, we are warmly inviting you to go to our Submit a New Case Study webpage that will also be shared in the chat, and reach out to us. Thank you very much for your attention, and I'm giving it back to Florian.
Thank you so much, Béatrice, for this excellent keynote and these insights. I'm positive we'll be able to address some of these issues in more detail during the Q&A in a bit. And again, to the audience, you're more than welcome to post your questions in the chat. So after having learned about the OBS-PACE action, we'll now hear from some of the PACE network members. And it's really great to have with us Antun Abud, who is a project manager for the National Lung Cancer Screening Program at the University Hospital in Zagreb, Croatia. Dear Anton, the floor is all yours.
Thank you very much, Florian, and I really want to thank the Observatory for inviting the Croatian team to present a little bit of the National Lung Cancer Screening Program in Croatia. In October 2020, Croatia launched a nationwide lung cancer screening program. At that point, there were 16 centers in 13 cities. In the past 4.5 years, we've managed to expand to 24 centers in 17 cities, and taking in mind the theme of this webinar, addressing inequalities, so we've managed to achieve equal regional distribution in Croatia. That means that all the rural parts of Croatia are also can also go to lung cancer screening. Another big thing is that the lung cancer screening program is fully reimbursed and fully integrated in healthcare system. So there is no need for any of the participants to pay anything or contribute to the payment. How did we start this program? So we recognized that there was really a high prevalence of smoking and really high incidence of lung cancer. Same as in Europe, same as in whole of the world. Lung cancer is the most deadly cancer in both genders. we made a team that was really multidisciplinary: pulmonologists, radiologists, thoracic surgeons, radiology engineers, representative from the Ministry of Health, patient representative, administrative representatives, IT. So it was really a big team because it was a national program and we needed to address all of the things. Croatia National Lung Cancer Screening Program is completely digitalized. Why is that important? It is important because we created a patient pathway that is much faster than it was before. We connected all the general practitioners with all the radiology centers, with all the pulmonology centers, and it was built on top of the existing Croatian healthcare digital database. So that meant that we can open time slots in each radiology center. GP just logs on to the digital platform that was installed on their computer and just choose from one of the existing time slots and directly enroll the participant. To continue on that, so primary care and GPs are the central point of the whole program. So we connected more than 2,000 GPs in the whole of Croatia with all the radiology centers. There were no invites, there was no media coverage. Also, the general practitioners don't have to call the participants, they don't have to search for them. So when a participant or when a patient comes to the GP can see the enrollment criteria. All the GPs know their patients, so they already have a clear view of who can, who cannot join the lung cancer screening program. And so they just enroll them. Basically, all it takes is a 1-minute talk and 1 minute of basically clicking through the digital platform. The National Lung Cancer Screening Program in Croatia is conducted by low-dose CT, and we are reducing the radiation burden every year. So we are also trying to address that point. Where are we now? By May 2025, we have enrolled more than 45,000 participants that have done over 60,000 low-dose CT scans. So for a country that is a bit smaller, like Croatia, that is really a huge number. And we are at this point, we are at a rate of approximately 2,000 scans per year. We are now doing a big analysis to see how effective our program is, and we are seeing already a stage shift from stage 4 to stage 3 and so on. We have approximately 25% more stage 1 cancers that are now treatable and operable. Regarding gender inequalities, we are now at 54% of males and 46% of females. Taking into account that more males than females smokes, this is basically 50-50 in that terms. As far as addressing inequalities goes, this is what we wanted to present from the Croatian side, and thank you once again for the opportunity to join and to be on this webinar.
Thank you very much, Antun. That was very clear and really impressive results. So congratulations to you and the team. We appreciate these experiences from Croatia. For a second country experience now, I'm excited to invite Lydia Villanova. Lydia is a scientific project manager with the Alliance Against Cancer in Italy and will tell us about a project on cancer genomic profiling there. Dear Lydia, over to you, please.
Hi, Florian. Thank you for the nice introduction. It's really a pleasure to be here today. So I hope you can see my slides. And the case study I'm going to tell you about is the GerSom trial. The project was meant to fill the existing gap, consisting in having two separate cancer diagnostic pathways for prevention and treatment of cancer patients. Indeed, as you can see from this schematic, As you can see from this schematic, the prevention pathway for identifying germline mutations associated with cancer genetic risk has been traditionally separate from the treatment pathway, aimed at the detection of somatic tumor mutations that are actionable. In other words, those mutations that are informative for personalized treatment and prognosis. So to address this unmet need, Alliance Against Cancer launched the GerSom trial, a prospective observational study funded by the Ministry of Health with a 6.4 million euros budget over a 3-year period from 2019 to 2022. And involving 26 research hospitals throughout the country. The objective of the trial was to test the feasibility of a joint diagnostic pathway, bringing together prevention and treatment with a single test at cancer diagnosis. So the ambition was twofold. On one hand, to better treat the patients by tailoring treatment according to the molecular targets identified with the next generation sequencing panel. And on the other hand, prevent cancer in their high-risk family members by referring them to geneticists for genetic counseling and directing them through dedicated prevention pathways. So despite a delay caused by the pandemic, actually the project achieved its main goals. So first of all, the genetic profiling of over 2,500 patients who could benefit from both personalized treatment and prevention pathways for their high-risk family relatives. And also the validation of a customized, cost-effective, high-throughput next-generation sequencing panel that had a higher throughput and higher performance with a lower cost as compared to commercially available panels. And another aspect that I would like to emphasize is that a capacity building program was carried out in underperforming centers by equipping them with cutting edge next generation sequencing infrastructure and personnel units to support the local expertise in data analysis and interpretation. And last but not least, shared the standard operating procedures and guidelines for internal use for the interpretation of germline and somatic variants were jointly developed in a multidisciplinary effort across all centers. So bringing together geneticists, clinical researchers, bioinformaticians, molecular biology experts, clinical data managers, everyone to really share these common operating procedures and guidelines. So overall, the GerSom trial really represented a national effort to raise and harmonize the standard of care and treatment throughout the country, also tackling the existing disparities within the country with northern and central research hospitals usually having a higher capacity and more advanced technologies. So I really thank you for your attention and hand over back to Florian.
Thank you so much for these really interesting inputs, Lydia, and for contributing to the OBS-PACE network and to our website. Now, moving over to Ireland, from where Maria Gillespie, who is the Assistant Director of Nursing for the Acute Haematology Oncology Nursing Service, will share another innovative action. Dear Maria, could you please come in?
Thank you, Florian, and thank you to the Observatory. I'm delighted to talk today about the Acute Haematology Oncology Nursing Service in Ireland. So what is this service and how does it work? So it's a national nursing service in Ireland for patients with a cancer diagnosis who are on treatment and become unwell with either cancer treatment side effects or as an emergency complication from a known cancer diagnosis. In Ireland, we have 26 hospitals that deliver systemic anti-cancer treatment across the country. So when patients receive their treatment education, they are given the details of how to contact the service if they need to. This is a non-ED direct access route for patients. They can access a clinical nurse specialist through a dedicated telephone hotline number called SOS, Sort Out My Symptoms hotline. When the patient calls the hotline to discuss a side effect or a symptom, the nurse specialist uses the UConn's triage tool to assess and manage the patient's symptoms. And this is a clear, symptom-based risk assessment process that uses a red, amber, green scoring system to triage patients who contact telephone lines with side effects or toxicities of systemic anti-cancer therapy. So advice, support, and further management is planned based on this assessment. Early intervention, ED avoidance, and hospital admission avoidance are really key aims of the service. So, for example, if a patient calls with a side effect or symptom that requires advice and support, it can prevent that symptom becoming worse and requiring hospital review. Unwell patients who require additional review or treatment are, where possible, seen in the cancer daycare unit or a dedicated space away from the emergency department. And all stakeholders agree that keeping cancer patients out of the emergency department where possible is crucial. I'm going to talk a little bit now about the background to the service. So the service was set up following the National Action Plan published by our Department of Health in Ireland in March 2020 in response to COVID-19 and was inspired by UK initiatives. So the National Cancer Control Programme advocated and secured funding for clinical nurse specialist posts in all of the 26 systemic anti-cancer therapy hospitals in the country to safeguard patients and minimise, where possible, their attendance to the emergency department and their requirement for admission to hospital. Close collaborations with our UK colleagues was key in setting up and shaping this service. Our UK nursing colleagues travelled to Ireland to train our nurse specialist staff in UConn's triage assessment, and we continue to have a really close working relationship. The service has been in operation now in Ireland for 5 years. So our national nursing metrics quantify the need for the service, and they highlight that many of the patients undergoing cancer treatments who are unwell can be appropriately managed outside of the emergency department setting. The NCCP serves as the national leader and driving force, uniting and guiding this development of the AHOS nursing service in our commitment to excellence and to standardised care. And just to speak a little bit about the growth since 2020. In 2020, the service received 1,137 calls. Last year, we received 21,873 calls. We know this works. We also know that out of the patients who do need to come to the hospital to be reviewed, 60% of these patients are reviewed, treated, and discharged on the same day. So providing same-day emergency care. So really strong foundations have been laid, and we are really well positioned to grow. The patient's voice has been really key to service development from the outset, and equity of access has been central from the very start, with national rollout from day one. Future funding will follow health needs assessments to ensure that all regions across the country remain fairly resourced. All of our patient information materials have been developed in patient partnership. The same name is used for the dedicated hotline service across the country, and as a result of our patient partnership work, we now have national standardised patient information in 10 languages. And this summer, we will launch patient information materials for individuals with intellectual disabilities, as well as those with visual and/or hearing impairments. And we have also recently added video-enabled care as part of our digital strategy. So although much has been achieved, there are vulnerabilities in the service. So what are the next steps? So our greatest challenge associated with the existing service is the lack of 24-hour access for patients. There's no dedicated nurse specialist in the service after the hours of 8 to 4, Monday to Friday, and there's no leave cover. So our aim is to achieve a 24/7 cover to meet growing demand and to reduce ED dependency. This year, we are really focused on scaling up the service, and we are in the process of recruiting additional nurse specialists. This has been made possible by newly secured ring-fenced funding of 0.7 million. So 18 additional nurse specialists will be added to the service. Expansion of the service is backed by our HSE National Service Plan and our programme for government in 2025. So this service really shows what is possible in terms of timely, compassionate cancer care when you combine patient-centred design, national leadership and expert nursing together. I will conclude here and thank you all for listening.
Thank you very much, Maria, for sharing with us these insights on what I think we can certainly consider a success story from Ireland. And thanks to all the country correspondents, of course. So we've just heard now a set of concrete examples from across the EU, and it's a real pleasure to now bring in Domenico Fiorenza-Glanzmann. Domenico is policy officer with DG SANTE at the European Commission and will reflect on those country experiences, share some thoughts, and maybe even a bit of an outlook from the European Commission's perspective. So, dear Domenico, you have the mic.
Thank you, Florian. I'm currently at an event in Luxembourg at the theater. I hope the background noise, which from me is very loud, is not very obvious for you. So I just want to very briefly recap the cancer plan, which has been introduced already by Florian, as it was adopted in 2021. So we are already 4.5 years into implementation, and implementation is going well. So we had a cancer plan review published in February of this year, affirming the ongoing relevance of its action, and also the cancer plan implementation was reinforced through the mission letter to our current health commissioner. As was already mentioned, there are 4 main pillars: prevention, early detection, diagnosis and treatment, and quality of life, and several overarching themes of the cancer plan: digital and personalized medicine, research and innovation, the goal to reduce inequalities, and to fight pediatric cancer. So I just want to comment very briefly on the case studies we've listened to. The Croatian example, of course, is very relevant for the early detection pillar. We have adopted in 2022 a council recommendation on cancer screening, which is focusing on the 3 more, let's say, established cancer screening programs: breast, cervical, colorectal cancer, but also as a novelty introduces recommendations for lung, prostate and gastric cancer screening. And Croatia has been very timely and a front runner indeed across the EU to go ahead with their program. We have one related project. It's a project Solace on the implementation of lung cancer screening programs in Europe, which I think can learn a lot from the Croatian experience. And for example, also has a dedicated work package and is running pilot studies on the enhancement of female participation. So it's very encouraging to see that the Croatian program is already reaching a gender balanced audience. And also very nice to see that the potential regional disparities are taken into account. The Italian example, I think, is very relevant in terms of harmonizing care standards at the regional or national level, which is also one of the main goals at the European level and of the EU cancer plan. So aligning very well with the overall objective here, again, to reduce inequalities. Then the strategy to personalize prevention and treatment aligns, of course, very well, and to strengthen and build capacities in less advanced hospitals. If we take that to the EU level, for example, one of the major joint actions funded through the EU for Health program is the EU Joint Action EU-NET-CC, which is setting up an EU network of comprehensive cancer centers and supporting specifically smaller and less resourced member states to meet the criteria for the certification. So this is a nice mirroring of this goal at the regional level. And finally, the Irish example presented by Maria, I think, is a really novel service, very interesting to hear and to listen to, and supporting also one of the cancer plan objectives I haven't mentioned, to learn and implement lessons from the COVID-19 pandemic. So it's a very important contribution both to the care and treatment pillar, and relieving the burden from emergency departments, and very importantly also to quality of life pillars, so catering directly to the needs of patients who face difficulties during their treatment. Then learning from other countries, I think, is a nice thing we have seen in the Irish example, even though it is from the UK. I mean, the UK not being a member state anymore, of course, we can still learn from their experience. And finally, the digital aspect is very relevant in the cancer plan as well. But that was just very briefly some linkages that I saw. And finally, I want to thank the observatory for hosting this webinar. I think these examples are very relevant, but it's the important thing is to get them out there to disseminate the findings so that other countries can learn from them. And so I also want to echo the call of Béatrice from the beginning. Please, if you have any more innovative case studies to share to this already very rich and diverse collection, please get in touch with colleagues from the observatory. Thank you.
Super, and thank you very much, Domenico, also for your intervention and your horizon scanning. And really, again, very many thanks to all of our speakers. I think we've really learned a lot over the last half hour or so, and I hope the audience feels the same way. Speaking of which, now I'm very curious to hear the questions from our audience and what's been happening in the chat. So maybe I can bring in Erica and Louise, and you can share what we've been seeing online.
Yes, hello, and welcome also from my side and from the background, from the chat. So there are a couple of interesting questions coming in, and we have guests from all over the world. And if you have more questions, feel free to ask. I'll start. Well, first of all, let me thank you also for these interesting case studies and also these different aspects you've had and you've mentioned. And I would start with Italy, or basic to everyone, but primarily to Italy. No, I'll go first for Ireland, and I'll ask Maria what has actually led to the success of your implementation and, well, to your service, and then maybe pass it on to the other countries, because I think we all can learn from all of these.
Thank you. Yes, so I suppose it's really important when we talk about the success of the service, it's really important to look back over the past 5 years. So much has been achieved in this 5 years, and really strong foundations have been laid, and we are really well positioned to grow. And I suppose our success is down to many factors. First of all, we have a really well-trained workforce of skilled nurse specialists in Ireland. So that ensures high quality patient care. That's the first thing. We've had strong governmental support, and our national health strategies. Support of the multidisciplinary team in each of the hospital is really key, and support of nursing management is really key in each of the 26 centres. Our shared learning with our UK nursing colleagues, really important to the success of this service. And our national leadership, this was really key. All of the hospitals started at the same time, and the service has grown together. And I think that has resulted in a really strong AHUS national nursing group. Terry Hannon, who's the National Clinical Lead for Cancer Nursing in the NCCP, secured my role. And that has really enabled us to be able to design and deliver a really clear, strong AHOS nursing strategy based on 4 pillars, which is quality, media and communications, education, and collaborations. And equity of access for patients and our patient partnership piece has been really key to that service development. And it really continues to shape our service. But I must say that the service does remain vulnerable. And the reason for saying that is that many centres, despite our uplift of 18 staff that we will be putting into the service this year, many centres will continue to have only 1 nurse specialist in place. So that means that basic level of cover in order to ensure leave is covered is not yet achieved. However, we are working towards building the service, and each piece of our AHUS nursing strategy builds the case for advocating for further resources in our service.
Hello. I mean, is there anybody else that would like to talk about the successes of their programs and what they felt was behind those successes, while Louisa just gathers together some more of the questions, because it's been quite a busy chat?
Otherwise, I would pass it on to Antun, because there have been a lot of questions in the chat regarding your screening program, and there's a lot of curious people out there. A lot of them are about the eligibility criteria and what were they in terms of age, smoking history. How was this communicated? Are these screening programs communicated to the patients with the harms and the benefits? How did you educate all these 2,000 GPs and the radiologist centers? And were also the incidental findings communicated to the patients, or only the lung-specific findings communicated? So that question I would let you answer.
Thank you. Those are all really, really great questions, a lot of questions. I will try to address them. one by one. So regarding the eligibility criteria, per individuals aged 50 to 75 that are heavy smokers, what that means, 30 pack years. So at this point, 50 to 75, 30 pack years. Just to keep it brief, we have a lot more exclusion criteria, but these are the main ones, that age group and heavy smokers. Regarding the harms and benefits, so we designed a small booklet, 4 pages, not even 4 pages long, that explains the whole procedures, benefits, harms, and a smoking cessation page, because a screening program is not effective, or is, I wouldn't say meaningless, but it has to have a smoking cessation support for all the individuals. So they get a brief explanation of the program, benefits, harms, and a smoking cessation booklet. Regarding the training of the radiologists and the GPs, we also have criteria for radiologists in order for them to be enrolled in the program. So they have to be from a high volume thoracic center. They have to have a minimum of 300 CT of the thorax region per year, or in the last year. And we organize approximately 2 times a year a special education on cases of early lung cancer, on the IT platform that we use, and it is also used as a certification method. So before going through that education, they also cannot be a part of the screening program. So it is used as a certification part and also as a refresher course for all those who want to go there again. Regarding the GPs, we used the existing digital platform. They're all connected through that same digital platform, and we've done a short video instructions, so 3-minute long, and it basically explains also how to go through the platform, click here, click there, and also explain some of the things in that video. And we have even managed to get one famous Croatian director to help us in that field. So it is really a nice short precise video for them. We sent that video to all of them at the beginning, and it is publicly available on the web pages of the Ministry of Health. So anytime they want to, they can go on that web page and see how to do certain things. And also we really try to attend their congresses and be available for them. We've opened an email address just for GPs. So really try to be really in touch with them. Regarding incidental findings, I think was next. On the low dose CT report, there we measure emphysema and coronary artery disease. It is measured visually, and it is stated on the report. And based on that, GP does further workup and referrals for the person. At this point, we do not have precise guidelines as we have on lung cancer findings, but we are now in the process of redesigning the Croatian program, and we are working on including those precise guidelines too. I don't know if there was anything else. I think I saw one from Portugal regarding the GP involvement. In Croatia, all citizens must have a GP in order to use healthcare system. And recent survey found out that more than 90% of Croatian people visit their GP at least once during a calendar year. So that is why we opted for GP involvement in our program.
Thank you so much, Antonio. Definitely sparked obviously a lot of interest in the audience, and I mean it is, as we said, right, a very innovative program, and that's why we are very, very happy you're able to share some insights. Anything else in the chat that we can bring forward?
Yeah, I would also focus again on capacity building and direct this question to Italy and ask, how did you manage to build the capacity in underperforming centers?
Thank you, Louise. This question gives me the opportunity to better explain how exactly the capacity was built in underperforming centers. So basically 17 out of the 26 participating centers were equipped with cutting-edge next generation sequencing infrastructure. And also some training sessions were provided on how to use the GerSom panel. Several units of personnel were also recruited to these centers to support local expertise in data analysis and interpretation. And an interesting joint effort was made by the bioinformaticians and clinical data managers who convened regularly in a working group to develop standard operating procedures for the processing and interpretation of these genomic data. And last but not least, for difficult to interpret cases deriving from the genomic profiling with the GerSom panel, a supra-institutional molecular tumor board was established, gathering like multidisciplinary expertise, so from geneticists to molecular biology experts, clinical researchers, again, clinical data managers and bioinformaticians to develop clinical guidelines for internal use for the interpretation of the somatic and germline variants coming from the sequencing. And also, I would like to stress that as a long-term impact of the project, there is the introduction of the next generation sequencing profiling in the clinical routine throughout the country. So again, tackling disparities that are usually exist between northern and southern hospitals in Italy. And actually, this introduction in the clinical routine of the next generation sequencing really paved the way also for the development and publication of the guidelines for the molecular tumor boards that Alliance Against Cancer developed in 2020 in response, to the need of interpreting this complexity of genomic data coming from the NGS. And these guidelines were the basis of the legislative decree from the Ministry of Health published in 2023 on how to establish and what are the requirements of molecular tumor boards in the country at national level. So I hope this answers your question.
Yes, thank you. We have another question coming in regarding sustainability, and it's directed to Italy. However, I think we can also incorporate and ask Ireland as well, as in how would you describe the aspect of sustainability now? Is it implemented as a standard of care, your implementation? And yeah, how are you further on accompanying sustainability?
Yes, thank you. So the project was a pilot, so involving 26 research hospitals to test the feasibility, of this joint diagnostic pathway, as I mentioned before. So it has not been scaled up yet, but I was mentioning it paved the way for the legislative decree on the establishment of molecular tumor boards. That was a national effort, and now the next generation sequences is really the standard of care, for the genomic profiling for cancer patients throughout the country.
Thank you so much, Lydia, for this. Very, very good to understand. Would anyone else like to respond to this question on sustainability?
Yes, from the Irish perspective, we're delighted this year in 2025 that we've been called out in the HSE National Service Plan and the Programme for Government of 2025. for expansion. So that was fantastic news, because we know that where we are now, we're building and we have our plans in place for this year to build, but it means that we are being supported by the Minister for Health and the Programme for Government of 2025, which means that we can continue to implement our strategy, which is fantastic news.
Super. Thank you, Maria. And Beatrice, I believe you would like to come in?
Yeah, I could jump on this, and I think that resonate well with those 3 case studies, where generally across case studies we really see that piloting before scaling is really a key enabler. It enables to also maybe reinforce even further that multidisciplinary collaboration and that building together before scaling, and it seems also to be a good path toward then the sustained success of the initiative. And other points that seem also to come up quite often are this notion of continuous monitoring and regular evaluation also of the initiatives, and that again should really be thought from the beginning, because then it's facilitating the continuous monitoring throughout the entire project, and the flexibility where needed to keep sustaining those successes. And in terms of political will, it indeed seems to be a very important enablers. But then here again, there are also the notion of having clear strategies as well that might also help maintain that political will and help really ground those initiatives in practice.
Thanks very much, Beatrice, for putting this together. I think we have time for about one more question. If I look over to Louisa and Erica again, is there anything else that we could bring in now for a last round, maybe?
I would just maybe ask regarding lessons. I mean, you mentioned it right now, but we have these 3 case studies. We also have a couple of more on the website. What lessons you would take from these case studies, and regarding transferability to other countries in Europe or also globally? How could they adapt? And also maybe also the country expert wants to say, what are their key messages they would like to take home and give to other countries?
Thank you, Louise. And so maybe I can start before we dive into the 3 country case studies. I think it's generally a recurrent worry of hearing, well, we all have different health systems across the EU. However, I think that this project, and I hope that this also case studies that we're talking about today are showing that there are definitely opportunities for cross-country learning. The initiative might not be implemented exactly the same as it was in another country. However, some of the characteristics, some of the lessons in terms of what should also be foreseen and how to design and how to implement, a lot of those learnings can be adapted to many other country contexts. And so that's also really what we hope this project is bringing on the table. And we're also happy to connect you with experts if in your country you're thinking of doing something similar. And we're really hoping that this project will spark more cross-country learning.
Very, very important points. Thank you, Beatrice. And I would like to give the panelists also, or who has an interest in engaging and responding, now the chance also to respond to that when it comes to general learnings and the way forward.
I think from the Irish perspective, this, I suppose this has really just shown where patient-centered care and having a nurse-led model, a really clear AHOS strategy backed by government support, how effective it is, and I think your point there is really well made about having a clear strategy and then ensuring that support, from the higher levels is sustained. So that's been really important learning for us here.
Thank you, Maria. Anyone else for final reflections before I Antun, please.
Yeah, I can shortly summarize. So I would emphasize 2 things. The first one is multidisciplinary approach. I believe it is really important to engage all the stakeholders, all the physicians, IT, patient representatives, GP representatives. So together, all involved parties at one table, and so that everyone has the same voice in creating a national strategy like this. And the other part is optimizing resources, as in to get a clear view what you have in your country that you can use, that you can build on top, so that you really, really optimize your finances, resources, and everything else.
Thanks very much, Antun. Okay, I think this brings us pretty much to the end of this discussion. If there are no other interventions, I think we need to conclude now. So please let me thank everyone once more for this really rich exchange and for sharing so many relevant insights from the countries that we selected here as examples today. Again, to everyone online, if you want to find out more about those examples, but also many more, please do visit our website, the OBS-PACE website, where we have many more insights and learnings and findings there, and also started compiling those into cross-cutting analysis pieces just as rich, and really, really welcome your perusal there. At this stage, I would also like to flag other key publications that have come out of our recent work on cancer and in collaboration with DG SANTE, including a EuroHealth article. You can also find the relevant link in the chat, so please feel free to have a glance. As conclusion and wrap up from my end, so we have explored today quite a diverse set of initiatives tackling cancer across Europe, and I believe that what this has shown is that while the success of each of those actions clearly depends a lot on context, resources, prerequisites, and many other aspects in the countries, we have seen that through these and through other examples as well, how political leadership, patient-centeredness, piloting before scaling up, and also strong monitoring and evaluation processes are definitely enablers. And I think the last few minutes now, listening to Antun, Maria, Béatrice, Lydia, also made this clear again. Definitely all of those findings contribute, or those factors really contribute clearly to reducing inequalities in cancer care, both between countries, but also very importantly within countries, which is exactly in the spirit of Europe's Beating Cancer Plan, and also crucially translate into wider health systems lessons that go beyond cancer. Without a doubt, though, of course, a lot remains for all of us to be done in the fight against cancer, and I think we all agree on that it takes many more huge efforts across disciplines, sectors, and countries to advance in this fight. Okay, on that note, it's my prerogative now as the moderator to thank all speakers again, as well as our great audience joining online, and thank you very much again for those questions to keep the conversation alive. Well, the unfortunate news is that this brings our first webinar mini-series on cancer to an end today. But the good news is that we will run another webinar mini-series on cancer later in the autumn. So do stay tuned and watch this space and stay subscribed to the Observatory newsletter to receive the latest announcements on this webinar and of course all others going forward. We hope to welcome you there and to all our other events as well, of course. Thanks everyone very much and wishing you a lovely afternoon.
Thank you. Goodbye.
Thank you.